So today we have with us Dr. Ann Bingham. She is an OB-GYN practitioner. She received her undergraduate degree from Yale University and her medical degree from the University of Vermont. She has a certificate in plant-based nutrition from the T. Colin Campbell Center for Nutrition Studies and is a strong advocate of the role of plant-based diets for pregnant women to maximize both the health of mom as well as of baby. She currently practices OB-GYN at the Crescent Street OB-GYN clinic in Middletown, Connecticut. So thanks for being with us here today, Dr. Bingham.
Yeah, you're welcome.
It's really great to have you.
Yeah, thanks.
So let's just get right into it. Tell us about your practice and the types of patients that you generally see.
I am in a group of all women. We are 4 OB-GYNs and 2 midwives. I have a private practice in Middletown, Connecticut. We work out of a community hospital right in the middle of the state, hence Middletown. I have a practice that is very diverse, both in ages from adolescents to octogenarians and older, women from all over, lots of economic ranges and education levels, races, insurance options, self-paid, Medicaid, Medicare, private insurance. So it's a really varied group, which makes it fun.
That's great. So today we're going to be talking mainly about gestational diabetes, and this is basically a temporary form of diabetes that affects pregnant moms or expectant mothers. So let's just start right at the top. Can you kind of give us an idea of what exactly is gestational diabetes? What are we actually talking about here?
So we're talking about a disease that's unique to pregnancy in that for many of the women who are diagnosed with gestational diabetes, they were not diabetic before they conceived. And in the process of screening them, which is recommended guidelines to screen everybody, we uncover for some women insulin resistance to a level where they actually fail a glucose tolerance test and are diagnosed with a condition called gestational diabetes. For a lot of these women, what is wonderful about this disease state is that it's temporary. And for women who then deliver and are able to get their weight down and establish perhaps, get back to health after delivery, they can enjoy going back to not being diabetic after they deliver. So it can be a temporary condition, not for everybody. And some people were diabetic before they became pregnant, in which case that's not really the category that they're in. But because they didn't know they were diabetic, we sort of lump them all together in a condition called gestational diabetes.
Right. And what tests are done to show whether or not somebody has gestational diabetes or not?
So it's, our population has gotten so much bigger, overweight, that never before in my training did we screen people before 26 to 28 weeks of pregnancy. But now, if you have a mom who is obese, we are screening them early. But for the average patient who is normal weight, we would give them a challenge of a drink that is famously yucky, sweet, sticky drink. And they drink it, and then an hour later their blood is drawn. If they meet a criteria of having a blood sugar of less than 130 after that hour, then they're free and clear, and that's it. For the women that don't pass, as in their blood level is above 130, we screen them with something called a 3-hour glucose challenge test, which is much even less pleasant because they're fasting. And so they go into the lab, they drink even more of that stuff, and their blood sugar is drawn 4 separate times. And the diagnosis of diabetes is made if they fail 2 or more of the 4 tests. So that can be fasting. It's fasting 1 hour, 2 hour, and 3 hour. And so they are so we're waiting for all four of those values before we can declare somebody not a diabetic.
So if they fail any two of those four tests, meaning if their blood glucose is elevated in the fasting state or after 1 hour or 2 hours or 3 hours, any two of those, then that declares them as being technically a gestational diabetic?
Correct.
Got it. Okay, great. So you can almost think of pregnancy as being this opportunity for women to understand whether or not their glucose is elevated, because if they weren't pregnant to begin with, then maybe they wouldn't even have this test done in the first place. Is that right?
Oh, true. I mean, I think a lot of us live in a state of denial, and especially if you come to pregnancy overweight, this may be uncovered, earlier, because as I said, we're screening our obese moms even earlier than 26 to 28 weeks. Remember, a pregnancy is 40 weeks. So if we're screening them right when we first meet them at 8 to 10 weeks, we're uncovering diabetes in some of those patients that otherwise would have had no idea.
Wow.
Great. So suppose somebody does come to you, they fail either the first test or they fail the second test, and they get classified as as somebody with gestational diabetes. What are some of the complications of gestational diabetes, and how does that affect both the mother's health as well as the baby's health?
So there are kind of two ways to look at the complications. One is sort of short-term complications, which would be saying, okay, this mom has more risk of making a large baby. This is going to be an issue of growing a baby that is perhaps what we call macrosomic, which is greater than 90th percentile. So there are graphs, just like growth curves in the pediatric office. How tall are you? How big are you? We have graphs for how big a baby are you making. So in cases where moms are diabetics, we worry about them making too big a baby. So too big a baby is a problem for several reasons. One is that it's hard to deliver a big baby. If you deliver vaginally, it can be really traumatic and cause a mom a lot of morbidity to her, to the vagina, to the perineum, larger tears, harder recovery, bladder. And then there's higher risk of C-section. For the moms who deliver a big baby, we worry about the fact that that baby is designed a little differently. They tend to have a ratio of their shoulders tend to be broader, which also adds to the baby's morbidity being delivered. So there are more shoulder injuries with the nerves of the brachial plexus. There are more risk for not getting enough oxygen before delivery because the delivery is more complicated. Certainly C-sections add a whole level of complications with anesthesia, with recovery. And there's the risk also of preterm delivery in diabetics. There's a higher chance that they'll have hypertension and a condition called preeclampsia, which is also unique to pregnancy and can be life-threatening for mom and baby. There's a higher rate of stillbirth. And for the baby that's born, there are risks of having low sugars, having higher bilirubin, having just a harder time recovering and spending less time with mom because they're being taken care of in their own special care nursery. Then if you're going to sort of zoom out and say, well, what are the long-term issues for those kids? Those kids are more at risk for obesity, more risk for having diabetes themselves. So that's obviously down the road, but this is a population that just really from the beginning as you're watching just higher risks all the way around for both mom and baby.
So we were just at a medical conference not too long ago, and there was a speaker who was an expert on the gut microbiome. And one of the things that she was mentioning is that in babies that are born via C-section, they don't have the opportunity to get the vaginal microflora or the vaginal bacteria directly from the mom. So in a lot of pregnancies now, or in a lot of deliveries, what surgeons will do is they will actually take a rag and they will literally rub it on the mother's vagina and then spread it over the baby's face. And that helps to initiate the process of colonizing the baby's microbiome with beneficial bacteria. So do you also see that in the situations where babies are born via C-section, that you end up with an increased risk for, dysbiosis or altered gut microbiome in the future?
Well, that's such a long-term story to say, I'm not their pediatrician. I can say that these people already have their own microbiome issues, that we're not talking about somebody, I mean, yes, they have vaginal flora, but their whole microbiome is changed as people who are already in trouble down that path of having a meat-centric, dairy-centric diet. So what you're talking about is something called vaginal seeding. It's something that's beginning to become more popular, not among everybody. I would say, bugs, we've created a culture that's still afraid of bugs. And so this is not yet sanctioned by the American College of OB-GYN, for instance. I mean, it may not be long. It took, the pendulum swung really hard in the area of being sterile and free of bugs, and to come back to a world of bugs is exciting and fascinating. But it's gonna take a while before we figure out, okay, how do you then make those bugs safe for baby? Because we are already screening for a bug in the vagina that's a problem called group B strep that we don't want mom to have. So some of those patients are getting antibiotics in labor. So that's a bug you don't want the baby to have. So it's really interesting, but kind of more to come on that.
Very interesting. So we talked about gestational diabetes being sort of a temporary condition, but we know there's an increased risk for type 2 diabetes. How big of an increased risk is there, and how soon after delivering?
So, if you're talking about the mom who was not diabetic before she conceived, we discover she's diabetic. She gained weight in her pregnancy, and she continues to stay on that path of just not eating well. I mean, she's got, anywhere from, the numbers really vary, but it can be up to 70% chance of becoming a type 2 diabetic. And there's no question that these women, if you're going to compare them to their neighbors who weren't diabetic in their pregnancies, it's a lot higher. And then, obviously, if you've got the woman that you really uncovered, I mean, she probably was a diabetic beforehand. Well, she's already there. So when you're going to say, well, how soon, probably in those first 5 years is the highest chance that she's going to become a diabetic. But with age and with bad habits and a lifestyle that's not healthy, that could be short or long from now. It really depends on them.
Right.
So one of the main reasons that we actually wanted to have you on this summit here is because, there's a lot of women who are very curious about the answer to a very simple question, which is, what do I eat? What do I eat to reduce my risk for gestational diabetes? What do I eat if I have been diagnosed with gestational diabetes? And what do I eat to minimize my risk for developing type 2 diabetes into the future? And, there's a whole bunch of conflicting information out there about whether you should eat a more paleo style diet and restrict your carbohydrate intake, or whether you should go the opposite direction and eat a more plant focused diet. So, mothers are constantly receiving this information about having to gravitate towards more meat and more dairy because they're worried about their intake of calcium and of protein and of iron. In particular, those three things keep on coming up over and over. So, can you give us an idea? Is it necessary to eat meat? Is it necessary to eat dairy in order to sustain the health of, both mother as well as baby?
Oh yeah, I mean, not only is it not necessary, but it's risky. I mean, we know that moms who come into pregnancy having consumed more meat are more at risk for becoming diabetic. We know, it's interesting to think that, if you're coming into pregnancy, again, that's just this second conversation about the opportunities are, how are you going to prepare for being pregnant? So there's the woman who's been diagnosed asking this question. There's the woman who's thinking about being pregnant asking this question. So, we know a lot of harm that meat and dairy are causing. So, that age-old question of where am I going to get my protein? Where am I going to get my calcium? Where am I going to get the iron? It's all the same answers that the person who's not pregnant. It's all the same answers for the person, for her husband or her kids. You're going to get protein from plants. You're going to get calcium from plants. You're going to get, non-heme sources of iron are much safer for you. They're going to decrease how much weight you gain. They're going to decrease the chance that you become diabetic, and they're going to keep you out of trouble, keep you from gaining the extra weight that you're going to be left with, and decrease the chances of having hypertension, a big baby, etc. So, it's as much as a different category as this is, and it has a lot of mystique associated with you're making a baby. I mean, what's more important than that? What's more exciting than that? But it all comes down to the same way that you're treating your machine, whether you're pregnant or not. And so, I think you can have the same level of confidence. Lots of populations in the world that are eating this way, doing well this way, living good long lives this way, having babies this way too.
Right. Now, so if you have a patient and they've been diagnosed with gestational diabetes, what dietary recommendations do you give them? Give us an idea. Like what would you tell them to change? What foods would they be eating? We want to hear it.
I think what's so hard is talking to the person who has their cupboards full of the sugary cereals. I mean, their breakfast is, maybe Captain Crunch or Sugar Pops or, Honey Grams, and they're putting milk on their cereal. They may be thinking they need to have an egg every day. They're having cheese to go. The working moms are sometimes eating on the go or having stuff in their bag that's, the ham and cheese sandwich, the fish, the deli meats. I mean, where do you start? How do you really do an about face? And for some of those people, they're going to be motivated, just like the person who's smoking a pack a day. They're going to be motivated to quit entirely. And then you've got the person who's going to say, I can bring it down a notch. I can stop having my daily yogurt, or I think I don't need that egg every day, or I can have meat once a day instead of 3 times a day. And so, I think my job is to try not to kick them out of my club, so to speak, and to say that, everyone's welcome, having this spirit of, I'm going to keep trying to steer my ship in this direction. And now I feel is that if I want them to eliminate all of it, it just, I've got this really short window of time in their pregnancy to accomplish all this. Every little bit is going to help. Their numbers will improve because remember, if they're diabetic, they're checking their finger sticks. It's really intense. I mean, 4 times a day, their fingers are sore. They hate it. Sure. And they're finding, their numbers are all over the place. They're having, the dietitian has told them to have milk for dinner. Or 3 times a day. They're getting such conflicting advice. So what am I telling them? I'm telling them, can you get rid of your white rice? Can you just make a switch to brown rice? Can you have a meal where it's half and half and just try to transition to all brown? Can you have brown pasta? Can you start to fill, can you hide a bag of baby spinach in the marinara sauce that you're making tonight for the pasta? But we live in a culture where people are wanting fast answers. They're taxing their kids to hockey practice and to Boy Scouts and, just even staying away from soda. I had a patient lose 70 pounds in her pregnancy just by stopping soda. I mean, wow. That's incredible. Just goes to show how much soda she was drinking. But so you got to decide of a spirit of, is every little bit a help? It is. Is it perfect? Most of the time it isn't. I mean, it's really hard to change on a dime when your back is against the wall. But people will do it.
Right. And you said some important things. You said you would have people eating brown rice or brown pasta. So I just want to cover. So let's say somebody was going to do exactly what you told them to do. They're the perfect patient. That you're telling them they can eat carbohydrates. You're telling them a pregnant woman with gestational diabetes can eat brown rice, brown pasta.
And potatoes. Yeah. Yeah, absolutely. I mean, the more the better. I think that's such an important staple and has been for our whole human history. What people get so hung up on are, the science of food, when really, what mammal is doing that? I didn't have enough protein today. I didn't have enough carbs today. Just eating real food and thinking about going to the grocery store and eating things that where they came from. You can recognize the ingredients. Sugar isn't in the first three ingredients. You're talking about limited ingredients. If you go to the grocery store with a few simple rules, unfortunately, you can barely come out of there with anything that didn't come from the ground. And for the person who's used to having frozen meals, the pizzas, the hot dogs, the deli meats, the cheese, this is overwhelming, and it can be sometimes to the point where they shut down, and they certainly don't want to see me again. So I have to walk that line between being the coach and the pep talk without being discouraging and negative, even though it's easy to feel that way when they're uncomfortable, they've gained so much weight being pregnant, they've got a big baby in there, they're miserable, they're saying I feel miserable, and you say, I can see why. You're carrying a lot of weight on those hips and knees. That's hard.
Right.
Yeah, one of the things that I've noticed over and over again is that pregnant women who are diagnosed with gestational diabetes are constantly told by their doctors to focus on eating foods that are high in protein. Okay, protein is the answer. That's what they're told. So as a result of that, they gravitate towards yogurt, they gravitate towards cheese, and they gravitate towards eggs. Those are the three foods that I see very commonly eaten by women who have gestational diabetes. But what they don't realize is that by eating those foods, they're actually making themselves more insulin resistant, and they're actually exacerbating gestational diabetes. So I'd say it's mildly frustrating, but it's also something that we want to sort of start to change the dialogue so that people aren't necessarily gravitating towards foods and they're going more towards lower fat whole foods, like you mentioned earlier. So is it a clear difference in your practice between the mothers who are gravitating towards more animal products and the mothers who are gravitating towards more plant products? Can you differentiate between the two of those?
I have so few in the plant product. I've had a couple patients who really did transition, and it was exciting for them to see that their sugars were better. In fact, we could start letting up and saying, you only have to check them now every other day, or maybe a few times a week, because your numbers are so good that I'm much less concerned about the effects of diabetes for your pregnancy. But my numbers of taking care of diabetes just keep going up. But my numbers of women who are able to transition in such a short period of time and get themselves out of this hole that they're digging, is too few. It's too few to be able to answer your question and say, oh yeah, I had 100 patients who did it this way and 100 who did it that way. I just don't have that kind of I think it's having, what you're talking about is having confidence in plant-based foods, having confidence that these are foods that are going to do the right thing when every message they have gotten their whole lives, from their parents to their grandparents to their friends to the television to the media, is you need to have milk. I mean, come on, it's basic. You need to have milk. Absolutely. And so to be that one voice, and then when I send them to the dietitian who tells them the same thing, I mean, I'm a heretic. And, is the problem, is that how do they trust me when every message they've gotten, and even their primary care doctor, the rest of our professional brethren who just don't understand nutrition very well. It's hard to convince those people to be confident in Mother Nature.
Yeah, it's a big issue. Would you say the logistics of doing the lifestyle is a bigger problem, or is it the fact that they just don't have the information, they don't believe it?
I think anytime I think people put up barriers often. So they'll say, well, I just don't have time to cook. I just don't have time to think about this. And it does, if you're trying to figure out, you just take this big piece of meat off your plate and you want to fill it with something and you don't understand that another starch is okay.
Hmm.
You can have rice and potatoes at the same meal. There isn't a reason, or you can have another vegetable besides one. So this idea of kind of thinking outside the box, I think is scary. It feels time consuming. I don't know what my kids will eat. I don't know if my husband will eat that. So what they don't realize is they've made such an investment often getting pregnant. They want nothing more than a good outcome. And they're steering themselves right down this path that's just going to make things harder and worse and scarier and riskier. And that nothing is more important than investing time and figuring out how they're going to eat this way. But I think it's both. I think it's really, some of it's intentional. I can't possibly do that when a lot of the ways to cook this food is just as quick, and we get in just as many ruts of, most people have about 4 meals that they rotate. So do vegans. It takes work to get out of that box for all of us.
Yeah,
absolutely. So one thing that we have talked about in the past that I think is absolutely fascinating here is that the food intake of the mother can actually affect the taste buds of the child. So can you kind of go into a little bit of detail about how that works?
I think it's more observational than in terms of saying how it works. To
Fair
say
enough.
that there are a lot of examples I was reading Greger, Dr. Greger has some pieces on this to just say that there are a lot of examples in biology where, the coat of the vole delivered in the winter has more fur than the coat of the vole being that's born in the summer, or the sweat glands of somebody who is raised in a hot climate versus somebody who's born in a cold climate. I mean, there are lots of examples where the environment puts pressure on how we, what we turn to and what we like. And so if you look at babies that are breastfed, for instance, 6 months solely breast milk compared to babies that are on formula. Formula is a very, it's the same tub of the same stuff that comes out. So if you're going to look at the variety that a baby is getting with their mom's milk, just changing all the time. What did you have for breakfast? What did you have for lunch? What did you have for dinner? The taste buds are different. And so there is probably something related to that exposure that's happening in the milk. That means you're just much more likely to find those tastes familiar later on in your life when you're eating solids and you're being introduced to things. So, I think it's just really interesting. On the other hand, as I was mentioning to you in a prior conversation, it just what's particularly tragic about obese moms and diabetic moms is that they're just much more or less likely to make prolactin, which is the hormone that produces milk. So this very population that so badly needs to nurse their baby often can't, and that just really seems that much more tragic about how do you get out of this rut that you can be swirling in. So these moms, for a variety of reasons, are having more trouble nursing, and some of it is their baby might be in the nursery now because the baby has low sugars because the mom was diabetic in utero. The baby in utero now has been exposed to all this sugar. Pancreas is jacked up, making all this insulin. Baby's born, and now their sugar levels plummet. So now you got to feed the baby some sugar water to help the baby kind of stabilize. So mom doesn't get to be with baby. My baby mom needed now a C-section because she made a 10-pound baby. So now she's sore. Now it's hard to move. So nursing is just that much more difficult. And anyway, it's just one domino falling after the other. And it just doesn't have to be. It doesn't have to be.
So let's do a quick thought experiment here. Suppose a mother delivers a baby. She had gestational diabetes. She delivers a baby. The baby might be slightly larger than is expected. And she's having a difficult time breastfeeding because she's not making prolactin. And as a result of that, she's having to resort over to formula. If the mother decided to make a dietary transition at that point and say, okay, great, I'm going to go towards a more plant-focused diet so that not only I can increase my breast milk production, but I can also just become, I could lose a little bit of weight and become healthier. How quickly would that mother be able to produce milk? Are we talking, days, weeks, months? Is there any evidence to support that?
I don't know that work has been done to say, are we talking hours? Are we talking days? I mean, breast milk production is fascinating and a science in and of itself. And lactation specialists have a degree process where, it's really interesting, cause and effect. So the more you nurse, the more milk you make, but there's a delay. So there's probably about a 36-hour delay when you have heavy demand and the baby's having a growth spurt and you're nursing more often, and you're not going to make a lot more milk in 10 minutes, but in another day and a half, your breasts are thinking, hey, you're feeding more, you're going to make more. You go back to work and you're not able to nurse as much. Your boss won't let you pump as much. So now you're pumping twice a day where you were feeding your baby 4 times a day at home. Now you're, no matter what you're eating, your supply and demand there is playing a role. So there are a lot of variables that go into it. And, you've got how well is the baby latching, how devoted and determined is mom to make this work. So, I mean, my first response would be, eat better. That can only be a good thing. And then pump and nurse and pump and nurse and pump and nurse until you're making more.
Now, I want to learn a little more into the details here so the audience can understand. So somebody has gestational diabetes. They're eating a poor diet and they come to you, or they got diagnosed by you, and they change their diet. What things would they expect to see? Let's say they did it properly. They did the diet that you want them to do. What things would change? How quickly would they change? How does that whole process work?
I think
the first day.
I think the most immediate thing that they would notice, besides maybe they weren't constipated anymore, they were feeling better, they had more energy. I think the most sort of objective thing they would notice is their finger sticks. The values that they're getting. I mean, literally, they're checking them 4 times a day. That's a lot of feedback that you're getting from the food that you're putting down the hatch. So, you're just going to immediately say, hey, my fastings aren't so high anymore. I'm not getting numbers that are in the low 100s or high 90s. I mean, we're much more particular than the standard patient who's got type 1 or type 2 diabetes. Say we are really looking for tight control to limit complications. So I'm looking for a fasting under 90, and I'm looking for a value 2 hours after eating that's less than 120. So, so that's the first thing that they're going to say is, I'm getting numbers that aren't so high. That feels good. I mean, most people want to follow the rules. Most people don't want to be outliers. They don't want to fail. They don't want to look bad. This is so out of their control, they think, and it seems so random. But I had an egg sandwich yesterday and my sugar wasn't high. Why is it high today? These are things that, how much exercise did you get? What time of day did you eat it? What else did you eat it with? There are a lot of things that are really hard to answer individually, but I would tell you immediately they would notice their finger sticks are better.
Excellent. And again, just so people can understand, you see this in patients, you have seen it in patients, they start eating brown rice, they eat pasta, maybe they eat some fruit, and they actually see their blood glucose numbers come down.
Yeah. And you see that their weight stops, kind of, they've had this trajectory of like they're gaining, 2 pounds a week average. And now they start to slow down. And again, then they also just start to feel better. And then some of them will say, gee, I feel so much better this pregnancy than I did last pregnancy. So it's exciting when your body starts to give you that feedback immediately of, my belly doesn't hurt because my bowels are moving much more frequently. I'm not getting all that bloating feeling. I just don't feel so heavy. But again, it's such a unique experience to be pregnant. So often you don't really know what to expect anyway.
Right.
But then on top of it, with a bad diet, you've got 30 feet of colon that are constipated inside this growing uterus, with a uterus too, and inside your belly. That can be really uncomfortable if you're eating poorly, for people.
It's amazing. I mean, it's great to hear it from, doctors like yourself in the field working with people, because that's really what this whole summit is about. We want people to know that with whatever form of diabetes you're living with, you get to eat whole plant foods, that these carbohydrates that are in these whole plant foods actually result in better health. They don't cause blood glucose problems. They actually solve them.
Right. And you just want to stop those dominoes. Like, it's in your power to stop the dominoes. Like, don't go there. I mean, if you're lucky enough to be able to make these changes before you conceive, that's so much better. I mean, we know that having high sugar in pregnancy actually increases the risk of birth defects. I mean, that's so frightening to think that, your high sugar might influence whether your baby needs cardiac surgery at birth, or doesn't survive, or has a central nervous disorder, or, it's that much more empowering and exciting to think that you can really affect change in a way that nothing else is more powerful than what you're eating.
This is so good. One of the things that I want to make sure that we do in every single talk in this summit is be very clear about what the recommendations are. So I want listeners to walk away from this from this session and say, okay, Dr. Ann Bingham says that if I follow these recommendations, then I can have a much healthier pregnancy. So let's basically lay out what your recommendations are for somebody who is either at risk for gestational diabetes or currently living with gestational diabetes. Can you kind of sum it up into maybe like 3 or 4 different take-home messages?
I would say first, get rid of the meat, get rid of the dairy, get rid of the eggs. I mean, just if you can get rid of it entirely, that's the best. If you can move towards that, that's the goal. If you can move towards a diet that's got more fiber in it, you're going to be happier, you're going to feel better, you're going to be healthier. So that would be, transitioning to, again, the brown rice, the brown pasta, and really working towards looking in the cereal aisle at, at the very few foods, very few options there that have more fiber, less sugar, less added salts. And then really trying to have as much real food as you can find, getting rid of the boxed things, which tend to just add more sugar, salt, and fat, so that your taste tends to adjust, and you'll be happier having the whole foods. They're going to throw in then, of course, being active, getting outside, exercise, which is so important for our mental health, so important for just feeling better. It's not as critical as diet for weight issues, but it plays a role in how our body responds to our caloric needs and just our engine staying moving. So that would be another piece of advice. And the rest is common sense, and again, not that much different from people who aren't pregnant, to say you really can have confidence in this diet. You can keep up a lot of the stuff you've been doing not pregnant from an exercise perspective. Sleep is so critical, and yet that just gets increasingly hard in pregnancy, and is a different category altogether, but is just really minding your machine, taking care of yourself, and you'll be rewarded.
This is great. So let's sum it up. You said reduce or eliminate meat, dairy, and eggs right off the bat. Number 2, eat foods that contain more fiber. Eat real foods that contain more fiber. Number 3, eat less added sugar, which can be accomplished by if you eat less packaged and processed foods, period. And then try to be active on a daily basis during your pregnancy. And then, like you said, mind your machine, right? Pay attention to your machine, because if you do, it'll guide you in the right direction.
Yeah.
This is great. Love it. Well, thanks so much for taking the time to be with us today. Yeah, I feel like I've learned a lot in this process, and gestational diabetes is one of those things that it's such a very specific form of diabetes, but there's a lot of commonality. The cellular mechanisms underlying gestational diabetes is very similar to what you would find in type 1 diabetes, type 2 diabetes, pre-diabetes. Yeah. And so it's actually good to hear that a lot of the recommendations that you set forth here are very similar recommendations to what we would set forth for other patients living with either type 1 prediabetes or type 2 diabetes. So this is really informative.
Good.
Yeah. Thank you so much.